Of course, we've had to make a lot of changes as a result of COVID. Those changes are related to keeping people who don't have COVID safe and preventing the transmission of spread. So, the key thing has been clearly trying to reduce interactions with the hospital setting to avoid people having to come out of their homes. So what that's meant is a lot of telephone consultations, video consultations, and just thinking about ways we can reduce necessary interactions. And when patients do have to come to the hospital, that's thinking about maintaining social distancing and keeping them safe. So making sure that we don't have people in busy waiting rooms and that people can come straight in, have their appointment and leave without any waiting around. Obviously, we've thought about how we might modify the therapies that we are delivering in terms of minimizing the risk of developing severe COVID, and we've made some decisions perhaps to truncate some therapies. And so there are patients who, for example, have had maintenance rituximab in remission of follicular lymphoma that we have stopped. And perhaps some patients with follicular lymphoma, we've made different choices about the chemotherapy backbones we're using. So of course with bendamustine, we're concerned about the long-term T-cell suppressive effect of the agent. I think there's been a move away from us delivering bendamustine therapy to CVP-based therapy because of the fact it doesn't have such profound effect upon T cells. It certainly doesn't appear to have any long-term effect on T cell functions. So maybe we're treating people in a different way. Our autograft program, for example, has turned its attention really only to those patients who have the highest priority, and some of those indications where perhaps the urgency is less important, such as consolidation of first remission in mantle cell lymphoma, or perhaps in use in indolent lymphomas, we have suspended until a time when the incidence of the viral infection has reduced. And I guess the third pillar of this is how we treat patients who have been exposed to COVID. Of course, that's about suspending their therapy, and for some patients it's meant a delay that might be clinically significant in terms of deliverance of next treatment, making sure that patients who have had COVID are clear, hopefully, before we reinitiate systemic therapies, and that trying to treat people who have been exposed to COVID on a slightly different sort of geographical area within the hospital to those patients who have not had COVID. So kind of a difference in our streams and our pathways about the way we are delivering care. So massive changes over the last few months. What we need to do is ensure that our pathways are such that we keep our patients safe and that we don't have transmission whilst patients come to hospital, and that obviously it's really important that we maintain all of these measures. Even though the prevalence in the community has gone right down, we know that our group of patients remain highly vulnerable to development of COVID, and obviously severe COVID if they do contract the viral infection.